In our program, we favor combination seeds followed by beam, with implant dose incorporated into the IMRT calc to allow full integration and correction. We have two options: 120 gray implant followed by 10 IMRT fractions, or 90 gray implant followed by 25 IMRT fractions. Prior to the OR, we import multiparametric MRI and map the aggressive tumor location, as well as base and apex anatomy. In this case, a man with low-level intermediate risk disease was found to have an aggressive lesion projecting beyond the prostate anterior, was visible on diffusion and ADC, and was extremely close to the external sphincter. Incorporating tumor information like this is the greatest advance in our practice in 20 years. In this case, we see a large 85 cc gland with a small deposit of intermediate risk disease at the apex. The transition zone is not involved, and the proximal 1 centimeter of the urethra is spared in the plan. Preop, our prep includes tamsulosin starting 3 days before, enema the day of, confirmed in pre-op. We use a laryngeal mask airway general anesthesia. We use a neutral 90-degree leg position to avoid hyperextension back injury. We then optimize the probe position by reviewing near probe and distant probe effects on sagittal view. Note the apex turns and opens up when the probe is farther away. So distance probe means slight loss of clarity, but more approachable apex. The apex moves from a pencil tip shape to an approachable surface. We also attempt to angle the probe down to improve the seed drop-off angle and avoid seeds dropping into the Bermuda Triangle, as we call it. Next, gold marker seeds are placed at the base and the apex. They are placed close to the urethra, an area we will not place actual seeds and therefore not likely to shift with actual needle placement. These are the first needles passed, and you get an immediate index of how difficult the case will be. In some cases, the needle passes freely through the prostate without binding. In more difficult cases, the needle binds, and high needle speed will be necessary to get the needle to the intended depth. Even on standard cases, the base plane moves superior or deeper into the pelvis as the case proceeds. Failure to fully reach the base is the most common technical error in the OR. This case was sent for salvage therapy. The entire upper prostate is void of dose and seeds. The entire GU diaphragm is fully dosed, including the upper penile bulb. The plan was actually reasonable, the execution terrible. Also, you get an idea of the depth the needles must be passed as these initial needles for marker seeds are placed. We want to avoid passing needles beyond the prostate because seeds may track to full depth, the so-called 80% rule. We advance the needles just before deposition to full depth. Ultrasound axials are obtained and the marker seed levels are noted. The needle system is a MIC needle based with locking cartridges that can be preloaded in real time. We can have seed, spacer, seed, or continuous seeds. We plan with relatively high activity sources unless the gland is very small, less than 25 cc's. We use a very peripheral approach with inner seeds at the apex and base, the so-called hybrid technique. Loose seeds are used throughout except for 4 2-seed strands for the seminal vesicle region. This overcomes the problem of loose seed movement near the seminal vesicle. When possible, the base is spared. Tumor is defined as a region, not boosted necessarily, but we make certain it is not cold. We use peripheral loading as stated with urethra less than 150%, but usually less than 135% of prescription dose. The order of needles: 4 needles are placed to 80% depth and left in as stabilizers. The next needles placed are apex. These are placed early in the case while the apex is clear. Apex needles are the exception to the rule that needles are passed quickly. The needle is gently nudged into the apex and the seed is dropped. Next, the rectal row needles are placed, preferentially anterior or lateral to ideal, to keep the rectum cool, but never posterior to ideal. The remainder of the needles are passed, always leaving 3 to 4 needles in if seeds are dropped. And seeds are dropped and monitored on sagittal ultrasound or in reference to the marker seeds, preferentially both. Fluoro is checked after each needle. Large deviations are simulated but resist correction seeds due to our error-tolerant planning style. We obtain an ultrasound post-implant to review seed distribution, especially at the apex, which is predominantly peripheral zone and at risk. Our post-implant planning is done 3 weeks after with MRI and CT. We incorporate brachydose into the IMRT calc to gain full control of high dose and dose limit novel OARs, including erectile tissues. This allows us to meet the modern definition of successful therapy: cure with quality of life.